Well, today I'm speaking with Carrie Mendoza, and Carrie is an emergency medicine physician and the director of FARE in medicine. And I am really excited to speak with you because I feel like I've talked with a lot of people for this YouTube channel that have been involved in this ideology from an educational or psychological standpoint, but how this is impacting hard sciences is even more alarming in some ways. It's just and so I'd love to get your perspective. Carrie, you did a fantastic video for FAIR that I've watched, and it's a pretty short video. I'll link that below in the description for this one so that people can watch that, and I encourage people to watch that. But you lay it out very well. And anyway, I'm delighted to speak with you, and thank you for being here. And could you first say a little bit about your background and what brought you to this conversation?
Oh, sure, Leslie. Well, first of all, thank you so much for, having me on and including me in this conversation. I do think that, physician voices need to be platformed more and physicians need to speak out more. So thank you so much. I am board certified in emergency medicine. I came to medical school a little bit later. I had worked for a few years after college. I had always wanted to be a physician, but I had a lot of heterodox interests, particularly I was interested in art history, and I got a master's in that, and then worked in a museum. I just really loved kind of, history and trying to understand human nature. I think that was the common thread, but I always wanted to go to medical school. So I went after working for a few years, and that had given me, some just real world work experience. So when I landed in medical school and all the training, I had, I think, a wider view of, just human nature and trying to make your way in life. So I think that helped me a lot as I was going through the training. And I think, in the field I picked, which is emergency medicine, you really see a certain slice of the whole healthcare system and just what's going on in society. I kind of call it the good, the bad, and the ugly. Certainly there's some amazing things in healthcare we've done, like, getting people quickly, through the emergency department to, say, the coronary catheterization lab if they're having a heart attack, or our stroke protocols. But what we also see in the emergency department, because we're a safety net, is the way the laws are in our country. We see people that fall through the cracks, whether, they can't get into their healthcare provider, or whether they having complications from, certain, medicines or procedures, and then just folks who are sort of on the margins of society with, drug and alcohol abuse. They all end up in the ER. And so for me, when I had come out of residency early in my career, was really sort of the run up with the opioid epidemic. And I was seeing a slice of it where there was a lot of indiscriminate prescribing and sort of misdiagnosis of people with quote unquote chronic pain, but they'd be, 18 years old with like a knee injury. So just the definition didn't make sense, but they were put on really heavy duty drugs. I saw a lot of young ladies who had like pelvic pain because of their period cramps, where, historically you would get Motrin. Now they were given heavy duty drugs. So I just started seeing this kind of disconnect between some policies that certainly start out well intended, but then the negative side effects of the net being cast out too wide was clearly landing in the emergency department. We probably could talk about that more later, but I ended up, I still practice, but I again see, these kind of overextensions of diagnoses and adverse effects. And I think in the healthcare space related to sexuality, I started seeing changes that were happening just with electronic health records and categorization, and then overuse of medications that didn't relate to a specific, diagnosis. And I got involved with FAIR because I saw an opportunity to discuss a lot of these issues that, physicians are concerned about, but don't really have an outlet for. And so FAIR has been great to platform conversations through webinars, meetups, social media presence. And that has really gotten me in the middle of this issue with gender ideology, because our community at FAIR encompasses a big umbrella of parents, physicians, mental health professionals, folks in the arts. And so it's really a great opportunity interdisciplinary wise to just bring these issues to the fore. So I think I'll pause there. That was kind of a lot. And I know we'll probably pull out some threads there.
No, it's great. It's great. It's a great background. And it sounds like coming into medicine after having already done quite a bit in outside of that field probably really makes you more relatable for the patients that you're serving. You probably can, I can imagine that you're drawing from a lot of real world experience instead of having been somebody who just went straight into medicine. And I can imagine that makes a better connection and a better bedside manner in some ways for you with your patients. And it's also interesting how you describe being in the field of emergency medicine, that you're seeing all this cross section of what other doctors are doing and what's going on in the field of medicine because of this catch-all kind of experience here. The opioid crisis, that's something that's been very interesting. It's been kind of this ongoing unfolding thing where we've seen, as you say, like these excesses in prescribing, and how does that relate to what we're seeing now in terms of gender medicine?
Yeah, I see a lot of parallels, and it is an analogy I talk about frequently. I think, a lot of folks are familiar with, maybe familiar with the very important element and storyline of like the, Purdue Pharma and the pharmaceutical companies and sort of how they, got involved in their role in it. But what I still find that is little talked about, that I try and bring into the conversation, is the role of how hospitals and physician practices work, and the incentives, in a bureaucracy that's developed around healthcare that really, I think probably, a starting point easily can be, in the mid 60s when Medicare and Medicaid were legislation that was passed, and not saying that those don't have merits, but it's a system. What grows around it then started a big bureaucracy. And an element of that is the bureaucracy needs to show what value it's bringing to the conversation. And of course, we're in a phase, I think, in somewhat of a, I don't know if it's an unwinding phase, but sort of a tipping point where, because of the demographics with the aging population, and because of expansion of Medicaid under Obamacare, which was like in 2008, it's shifted a lot of cost burdens to the states, and not to get into all that policy, but what happens is that there's just this constant drumbeat of like healthcare's too expensive, and show me what the value is here. So there's a lot of schemes out there in the regulatory world related to that. And why that's important is that, of course, there's a lot of, alphabet soup acronyms that are involved in healthcare. One of them is like, the quality people. And so they've come up with, tools that in systems that say, okay, hey, to measure quality for our dollar, for example, we're going to have patient experience scores. And there's a whole regulatory apparatus around that. And some of that had been tied to the pain scale, which was part of what was created to measure how well pain is controlled. But that came out of a quality initiative. And so what is little talked about is how, that pain scale was promoted and partially engineered by the AMA. And the AMA owns what's called the billing codes. It's the language for healthcare to get paid. And so on one hand, they're trying to show their value. They need to kind of create this whole world that everything is put into codes and scales and measurements to say, they would say like, hey, if your pain scale scores in terms of pain control isn't at a certain level, your reimbursements are going to be lower. So they created an incentive structure that hospitals and physicians felt they were basically coerced, which, should be illegal, that you have to prescribe medicines to get a certain score. So then you get certain reimbursements, and bonus schemes were tied to it. So, I think that is an element, these incentive structures that I say are, why don't doctors say no to things? And some of those elements have never been undone. They just ramp up. Under the Trump administration, they did disconnect the pain scale scores from patient satisfaction surveys. But this whole concept that the consumer needs to like their experience in healthcare is very, very embedded. And that relates now, I think, with gender ideology, because, I've seen little on people looking at, is the bonus, or is the compensation structure, say, for doctors in these gender clinics or mental health providers, how are patient experience scores related to their compensation? I'm sure that they are, especially if you work for like Kaiser and some of these big corporations. So I think that is just a continuation from sort of making the consumer happy, which of course what they want sometimes isn't actually what is medically indicated or good for them. And I do see that parallel here with the gender space, and this, why part of the groupthink, I think, is some of this regulatory apparatus that prevents and makes it hard for, I think, some people to go against the grain, even though when they know that they should be.
That's really interesting. And I hadn't thought of those pain scales. I kind of remember they cropped up out of nowhere, and it's the little happy faces and sad faces with the numbers underneath. But I hadn't realized that was so tied to reimbursements and like physician success outcomes. It sounds like it's really subjective self-report on the part of the patient. And that's interesting. And it does seem to relate, like on some level, when you're going to see a doctor, you do want to be satisfied that you received you do want to be treated for the thing that you're coming in for, and have somebody who hears you and provides you with the service. But for me, one of the things that I've been observing with this gender thing is there seems to be a big divide between elective cosmetic intervention and something that's really medically necessary. And we have this threat of suicide being this underlying linchpin that's kind of like this: if we don't do this, then this is this really horrible outcome, so therefore it's medically necessary. But at that point, that seems like a clear mental health issue. And if this person can't tolerate the distress that they're in to the point where they're threatening, and it's a threat, I'm going to end my life if I don't get access to such and such care. Well, I could see how that could extrapolate to lots of other things. And that doesn't seem like a sound place to base medical decision making on.
Right. I think, again, some of these elements with, the elective nature and the suicide narrative, I think, part of it does, again, why does this have so much, why is this so, like not questioned? I do think some of the other elements relate to, there's been a lot of consolidation in healthcare where there used to be most physicians just had independent practices. And, if they went to the hospital or they saw patients in the hospital, whatever, they had separate billing. But what happened, one of the inflection points, because of the way Obamacare was structured, basically giving the money really first to the insurance companies, big hospital systems consolidated and they bought physician practices. So there's, I think, depending on the discipline, there's over like 50% of physicians are employed by the hospital system. The reason I'm mentioning that is because the hospital system then it becomes that, they have to stay within like a regulatory framework that isn't, again, necessarily related always to quality, even though we talked about some of the quality metrics. And one way that this ties in is that, again, during the Obama administration, they have been trying to write in civil rights legislation into healthcare law. And, to some degree have, but there's been pushback. And the reason I'm mentioning that, not to get too in the weeds, is that health systems don't want to be on the other end of being called, saying they're discriminating. And we know the conflation with, sex and gender, but if you're the risk management person and at Kaiser and a big hospital system, they're not in the weeds with this like we are. They're just like, this is a risk. And so what happens is they just don't want to do anything that would be perceived as saying no to a certain patient population. So I think that's really important to understand, that they didn't necessarily say like, oh, these are elective cosmetic surgeries. They're looking at they're being told, and we can, we all who follow this know the way that that's like a, big push with the activists is characterizing it as discrimination. And that's even in some of the legal cases, we see that argument. But so a health system just is looking at it like, I don't want to be on the other end of discrimination. So I think that's important to understand. And then, of course, again, the suicide narrative, there's so many strands, but one of them, again, is that if you're seeing a patient, you don't obviously want to be on the other end of a bad outcome, right? And I think the activists have done, a very like strong job of, kind of having that be just the bottom line. And so I think a lot of folks who don't know a lot of the real data are just sort of like, I don't want to be on the other end of that, bad outcome. So I think that's, one of the challenges to educate people around that. But I think just if you had someone in your office, it can be, I think, really scary to these clinicians.
Well, it seems like at that point you're kind of held hostage.
Yeah. Yeah. I mean, to me, I mean, there's nothing in healthcare, when I got into this and heard like that, as I could see that was such a big driver, but it just rang, obviously, it just extremely manipulative and false to me, because there's nothing in healthcare, that you practice that you're just like, if you don't do this, you're going to commit suicide. I mean, that's just, no one talks like that in healthcare. It's a discussion of risks and benefits. And so to me, it clearly just was like outside the realm of healthcare. It's just that a lot of the social activist policies have been enjoined with the practice of medicine, but that's just nobody. I mean, yeah, it's just, we don't talk like that. It's manipulative. It's abusive. And so, but the issue is that there's a lot of people with able to prescribe things, as well as, write letters, for surgery that are sort of swept, seem to be swept away in it, instead of just saying, you're having issues here, but just the nuance of the medical conversation, and just really having the moral courage to say, there's no evidence. There's nothing in healthcare that, if you do this, everything's going to be great. And if you don't do this, you're going to kill yourself. That's not, that's not normal conversation. So,
and that moral courage, it is really hard to stand up against when you're not backed up by your organization. I'm sure that it's very difficult to be the person who's going to be, drawing a line on that with your patients.
It is so hard. And my first experience when I was new, sort of earlier in my career with the opioid issue was my very first time that I experienced the fact that what, I'm taught to do in terms of the Hippocratic Oath and just my beliefs about ethical care were not supported by the regulatory administrative structure. We could clearly see what was happening as more patients would come to the ER because like the pill mill that they were interacting with, is only open 9 to 5. And then there was people that were running through their prescription sooner than a refill. So the clinic would just say, oh, go to the ER. So we started seeing all these people like with these, some things were like they legitimately were withdrawing, which we would treat that. But some things were like, I lost my pills and my luggage at, the Denver airport. This is when I lived in Colorado, but like I saw this woman like 2 or 3 times telling me the same story over like 3 months, I mean, one story. So it was just like a parade of patients that were coming in that we knew were diverting and the nurses were just, it was so difficult because these patients, I coined a term, I would call them narco bullies because it was like they were addicted and there was this like part of their brain that's not regulated and they just would treat people so poorly. I mean, I had, one story was like a young woman I saw. I think she was in her early 20s. And this has echoes of like the group that has been caught up in the social contagion. So it was like this young woman and she had chronic pelvic pain and she was addicted basically to Dilaudid, which is a very, very strong opioid. And, again, I had mentioned before, historically, we like growing up, we all knew, there was always, those unfortunate girls who like in school would like miss school because their period cramps were so bad and it was horrible, but they would basically, do Motrin, Tylenol, that kind of thing. Well, there became this cohort of girls who they were putting on these heavy duty drugs because of this whole thing about treating their pain and the pain scale and quality. Yeah. And some of them slipped in and became addicted. And I saw this young lady who basically the clinic had stopped refilling her Dilaudid or it was too early to get a refill because she was overusing. She looked like a heroin addict. I mean, it was so sad. And she was there with her mother. And she wasn't acutely withdrawing, but I think it had been like a week or so since she had her pills, but she, needed her pills. And basically I just said, I listened to the story and, empathetic, talked about non-narcotic things, but I said clearly, you have an addiction problem. And I kind of went through that, the issues with that and how she wasn't able to function. And I said, I wasn't going to they were there basically for a refill. And I said, I wasn't going to do that because it wasn't good for her. It would be continuing on a path that was destroying her life. So she said to me, you are the worst doctor. I am going to complain about you. I'm going to give you a bad score. And the mother said, we live next to the president of the hospital and we're going to call him when we get home and tell him that you're a horrible doctor and, incompetent. And I said, okay, here's how you spell my last name. There were difficult things like that. And I had times that people kind of made veiled threats where I had to have security walk me out to my car after a shift. And I had times where I would be in my car at the end of a shift, like crying because it was horrible that there wasn't really a backup for me. You would just hear, in this case with this young lady, you know, I emailed my medical director saying, you may hear a complaint, here's what happened. And I documented my chart about, you know, the addiction issues and my conversation. And yeah, sure enough, the next day he said, yeah, they complained, but you know, our fellow doctors were very supportive, because we were basically seeing all these people. Sorry, my dogs are being crazy in the background. We were seeing all these people come in, and it was really hard to, you know, run the department. But I'm just saying things like that. The hospital administration didn't say, oh God, this is, you know, we support our doctors. They would say just kind of vague things like, oh, you know, doctors have to make their best decisions. I'm sorry that you had a bad experience, et cetera, et cetera. But they didn't so much, you know, do anything more than that. And it's really horrible when you are, you know, spent this time training, you really care about obviously doing the best for your patients. You know, you may have a heart attack that comes in after that or in between, because you're seeing 5 or 6 patients at once. And to just be told by people that you're a horrible person because you won't go along with their addiction, just, it does take, you know, a lot to stand up against that. To me, it just was crystal clear to me. But what's hard, and I think ongoing in healthcare for a lot of doctors, is this, you know, they call it moral injury. But there's little backup. And I think that's part of the problem, why physicians, you know, a lot of people I would see. Yeah, I had partners who were great people, but they didn't want to quote unquote fight with these people or discuss it. They just basically would, you know, write them, you know, a quote unquote refill, like, oh, I'll write you for 3 or 4 pills. So sort of to pass the buck, but they didn't want to get into the whole big, you know, thing about it. So I don't know if that, you know, makes sense.
Yeah, it really does. And it's, I mean, when you're describing I like that phrase, narco bullies, because it really does sound like that's what that description fits very well. The scenario that you described, and but it seems like it's a natural outgrowth of people having been taught that the priority is just pain suppression, and that's what they can expect when they go to the doctor. They can expect another prescription for this thing that helps them with this symptom. Yes. And if you are suggesting that there's a better way to do this, or that this might not be the healthiest way, then you've violated something that they feel really entitled to. And that seems like a very similar thing with the other ideological trends that we're describing.
Yeah, I think that's a great summary, Leslie. It's you get inserted. You're more seen as, you know, someone who's supposed to be facilitating everything. And if you say to them, you know what, this isn't right, I'm not going to participate in this. It's like, first of all, it's often the first time anyone has said no to them. And so they're just like, I can't believe someone's saying no to me. And then, you know, it's that, again, I think there's a lot of similarities with gender ideology and what's unfolded with addiction. It's like they're gender bullies. They come after you. They call you terrible names, you know, again, terrible names, all these things that are just, you know, no one's like calling you names because you won't, you know, give them their Lipitor or something. I mean, it's just like a different, thing. Like it's in a whole separate category. Like the way you described, like this doesn't happen in medicine, that we demand this or we're going to kill ourselves. So then the medical establishment says, okay, well, you can have this then. Exactly.
A whole nother category. The way that we were taught in the graduate counseling program about race and about gender and sex was so surreal to me that I'm in an applied psychology program, a graduate program, where we're teaching adult people to think this way, to reteach how we think about these fundamentals. And it's even more shocking to me when I see some of these, like there's the clip that went really viral like a year or two ago of this white coat ceremony where they're pledging to all these kind of ideological things. When you see this entering into medicine, it's I guess it's just a whole nother level. And I was in an experience where I was the patient year ago, and I was in a gynecological clinic after a surgery, and the doctors couldn't say the word woman. They wouldn't use the word woman. Like they were saying people with uteruses and things like this. And it's really surprising. Are you seeing that coming? Is there pressure to use gender neutral language and some of the stuff that you're seeing in medicine?
Well, not interestingly, and yes and no. So first of all, I'm not in affiliated with an academic center
Okay.
per se, and somewhat on purpose. I mean, initially my choice early in my career related to the fact that I had a young family and I wanted to do more, just shift work and not have to come home and like prepare for a lecture or do be at a certain meeting at a certain time. I really, once I have 3 boys who are now, young adults, teenagers, I really wanted to be home as much as I could and, make sure I had, the, solid marriage and make time with my husband and all these things. And we lived in Colorado at the time, and our family is in Chicago. So we didn't have any family support. So I had thought I wanted to do academic medicine because I also did a fellowship after residency in medical toxicology, which I really loved, which relates to, all the complications from medicines and poisonings and overdoses. But basically, I just made a choice after my fellowship that I just couldn't do academics well and be kind of the mom and wife that I wanted to be, and didn't want to miss like the time when the kids are really little. So I really got into a stream more of the non-academic world, more what we call community medicine. There's a lot of hospitals obviously in our, there's over 5,000 emergency departments in our country, and some of them are, just affiliated with just, community hospitals, not a big medical center. And the reason I'm mentioning that is that the academic centers, just like big universities, which a lot of these academic hospitals are associated with, just got sucked into the undertow with all the illiberal ideologies. And so some of those things really are not as infiltrated into the community hospital system. However, with the electronic health record being mandated by Obamacare, they basically had these regulations that hospitals had to start using electronic records. So what happened is there is a uniformity that's developed. And so I'm mentioning that because the electronic record, I think this was before COVID, somewhere in I think 2015, 16, 17, because the activists knew how to get into that stream back in about 2015, where they mandated the electronic health record started reflecting gender ideology. And so, one hospital I worked at, it was served more the gay and transgender community, and this is before COVID. I started seeing changes in the medical record where historically, if a trans identifying person came into the ER, you were always registered as your legal sex, your biologic sex. But we would write in the margin on the electronic board, John Smith, male, but in the margin, it would say, identifies as a woman, likes to be called Sue. Nobody had a problem. The staff didn't have an issue. The patient didn't have an issue. But all of a sudden, one day I walked in and they just said it was going to be, what we call now self-ID. So they started just registering people based on the sex, and it caused all kind of confusion. And I honestly felt it was like a safety issue. So
Yeah.
I sort of, and that was still in a community hospital system, but I basically migrated down more interestingly, to the south suburban area, the south suburbs and south side of Chicago. And because these really aren't big issues down there. And where I practice, there's been more issues with electronic health record, which we can talk about later, but it's just, classic emergency medicine. Most of the patients are African American. None of this stuff is they're there in the ER because they have a medical problem. There's no, they don't think they need to be taken care of by someone with the same skin color. They know quality when they see it. They'll say, I was in another hospital. I don't feel like they listen to me. Like, it has zero to do with identity politics. Those are luxury beliefs that have infiltrated. And I think it's almost like a jobs program. And I think it's part of the bureaucracy where there's a lot of PhDs and people who also used to be clinical, but don't want to practice anymore. So they're just kind of towing the line. But I haven't, it just, business is usual, mostly where I am, but I do know a lot of this is infiltrated into the medical schools. And I think you're just going to see a big lag. So I would say definitely you want to go with, doctors who are more mid-career, later career. And I think you have to understand the academic centers. If you go to, for example, an ER or a clinic in an that's affiliated with a big academic center, you are going to see a lot of this. So it's sort of I think it's like a wave that's cascading down. I hope that answered.
Yeah, it does. That's really interesting. It's interesting because your description of being in how being at a different proximity to the academic centers and in different demographic areas, different socioeconomic areas, there's a big difference in what you're seeing as a doctor and the patient population and their expectations of being treated in this particular way. And the luxury belief, you said it's like a jobs program. What did you mean by that?
Oh my gosh. I just, again, I think this relates to the way I see this giant bureaucracy in healthcare that has grown up because of, again, I think, when Medicaid, Medicare were created in the 60s, and it just sort of then required, lobbyists and they're a bureaucracy and proving that you're getting value. And there's just it's this whole world unrelated to actually delivering patient care, and I think that we see this in a lot of institutions. I think it's, my own theory is again, people will put different start points on it, but I definitely think, the 60s, there's an unwinding from that because of their failed policies. But a lot of people have jobs that are part of the bureaucracy that are detached from results. Again, I'm in suburban Chicago. I mean, that's just like this, to talk about the teachers union here in Chicago. I mean, there's in our state, there's school districts where there's kids have zero proficiency, in math and reading, but yet the bureaucracy keeps growing and people keep getting their wages increased. And it's unattached from results. And so I think that there is 100% a giant bureaucracy in healthcare that is part of this, quality and measuring and billing. And they just are part of the regulatory apparatus. So this quote unquote anti-racism and, gender ideology, has been pushed. As I said, some of the things happened during Obama era, and then Trump tried to undo some things, and then Biden has picked it back up, but they write rules into the regulatory apparatus. And then the hospital, then basically the government says, if you don't do this, you're not going to get paid. And then there's just all these people who have jobs to, measure that. Are you doing it? And, it's sort of a whole world unto its own that is this self-perpetuating machine. And I know there's great thinkers who've, I know, I think Chris Rufo has done a good job talking or sort of shedding, for folks who hadn't followed these things historically, shedding light on the bureaucracy that's there. You have to understand those people have jobs, if for example, like there's health systems that, after, during COVID, post George Floyd, just kind of developed, DEI departments. But yet, like, we have a problem staffing our ER because, like, they don't think about how do you keep, people incentivized to work in these tough places. They don't raise the wages enough, et cetera. But yet there's a DI department. I don't even know what they do. All I say is, like, can I get more help in the ER? These patients, the irony that the patients on the south side of Chicago that you purportedly say you want to help, well, we don't have enough staff. Why aren't you raising the wages? But yet there's some DI department. But now these people have like 6-figure salaries. And I think that they have to justify what they're doing. And it just keeps, kind of going and counter to actually what doctors and patients want and need.
It really seems like doing busy work because your main job is too complicated and you're stuck on something. Like, it's how do you measure and quantify in a bureaucratic sense when this thing has gotten so big and individuals and individual health is complex and hard to measure on some kind of a chart. I mean, I'm sure that they could come up with ways to make real measurements, but it seems like it's a really difficult and sticky question. But so we'll create these little scales instead. We'll play with, like, we'll give you this subjective pain scale because that's easy. And it's really easy to quantify and look at that across populations. And then the DEI thing sounds kind of similar. It's like, we're going to create things that can look like we're doing our job.
Yeah.
And instead we're really getting off, we're getting further and further off base from actual medical care.
Well, it's money that, again, for me, who's still, practicing, and committed to helping, like, folks who might not, be getting the best care or just have different challenges because it might be like working 2 jobs and they end up in the ER not because they want to, but because, like, the Medicaid clinic, isn't open off hours. Like, there's all kinds of, like, unbelievably creative solutions, but it's like that, unfortunately, is not what the system is about. But it's frustrating to see some department be created that's saying they're supposed to be helping, but yet I've never met anyone in that department. And how, if they're part of a hospital system, wouldn't you be coming to, say, like, the ER on the south side of Chicago to find out, like, what you could do? Like, so it's things like that. And the billing apparatus around healthcare, there's an army of people that have to be hired to try and extract money for the hospital to get paid, it's an irony that obviously isn't, lost on me or people like me, but it's also one of the drivers that has pushed good people out of medicine because they're like, this is insane. And then I think also with this anti-racist, and, the gender ideology, when I hear, this industry of, again, I think it's like trying to justify more and more research, but, like the journals and these things are all captured, but they're pumping out articles, calling doctors racist because they just do data mining and find a disparity. I mean, it's so, on one hand, it's so insulting and disgusting. But on the other hand, I'm just like, this is just activist stuff that I don't let it get to me because I don't know. It's just a sad part of what is going on. But I think, we have to build our own frame. I'm still committed to helping, people that are in need by just going to work in places that do that. But to see this, insulting, gross, like, calling people names and just data mining to find disparities, it's absurd. I mean, that's not even like how real medicine is practiced or what's really actually going on between the doctor and patient.
Yeah, that's really interesting. It is like you're taking these big aggregates and then making
Oh, yeah.
assumptions based on what you're seeing. And one
Yeah.
thing I wonder is that how with in specifically in regards to gender medicine and the hormonal supplementation or and therapy and the surgical therapies that are being done for people who have gender dysphoria, it how does that square with medical ethics training? The fact that you are so the dysphoria that people are experiencing, I'm sure, is very, very real in a lot of cases. And that's one way to treat it is through these cosmetic interventions. But it seems like that should be far down the line after you've already explored other options, because medically speaking, there's no way you're not compromising the person's health through these therapies. So they're not coming out medically in a healthier state. Their physical body is in a state of reduced health and reduced
Right.
strength, and I'm sure on all these different measures, a body that's been surgically modified like this, there's so much risk involved with these surgeries, and then the hormones as well. They're causing long-term health problems for the people. So
Right.
how does that square with medical ethics training, that you've taken someone and in order to improve an emotional state or a mental
Yeah.
state, you've degraded their physical body?
Yeah. Well, obviously, it's unethical, but it's within a thought. It's a way, I think, mental health issues have been shoehorned into, again, the regulatory apparatus of healthcare, which we were talking about earlier. It's obviously a material solution to a spiritual or mental health problem, right?
Mhm,
And
mhm.
you to understand how it's sort of caught up on the superhighway of when things go wrong, like we talked about with the opioid crisis, is that it's part of this bureaucracy and the way things are measured and the way the DSM is kind of, there's a whole history behind that. It's like checklist medicine that then can be put into X's and O's, into a scale, put into a code, because the language between your diagnosis and getting paid, again, is owned by the American Medical Association. I don't know if a lot of people know that they have a whole process in order to get new codes for diagnoses. If you don't have a code, you don't get paid. So if you're an independent, unless you're just fee for service out of pocket, but the way Medicaid, say, Medicaid and Medicare is done, and most things are just through this billing process. It's not like, you go to the gender clinic and they say, oh, it'll be X amount of money, and you give them the money. It's like through your insurance and the billing code and this and the that. So why that is important is because, mental health conditions have to be translated into checklists, because to meet the DSM criteria, because otherwise, if it doesn't meet that criteria, the insurance company won't pay for it. It has to have a billing code. Okay. So you have to, it's like they're shoehorning things. They have to make it simple and do a checklist and all these things in order, to get paid. And then you add in, the issues with big pharma, where, I feel that, again, obviously nothing's black and white, but they do wonderful things for, cancer drugs and all of these things. But there is a whole history behind, the medications for psychiatric issues. I mean, lobotomies never were actually made illegal. What they were replaced by the discovery of, the phenothiazine class, that actually just, they saw that it led to folks who had, agitated, like schizophrenia and things, that they were calmer. It wasn't like they were searching for that. So there's a whole history of how these things accidentally became the meds, and it's marketing. So what you have to understand is, in the psychiatric realm, the material realm with big pharma, to me, it's been a lot of market making. Like the analogy with ADHD, first it was marketed to adults, but there's a pattern. Then they need a new market, and they go down into kids, where, again, in the 90s, early 2000s, and unfortunately this has continued on, now it's just in the ether in these schools and everywhere that, every boy has ADHD because you could probably find whatever the DSM checklist, and so basically you have to understand, like, big pharma is part of the material nature of mental health. And if you can get a pill, then the insurance company might pay for that versus paying, for a therapist. So I think that that is huge to understand in this space, because if you have the formula of a medication, a billing code, and something that fits in a checklist and kind of can quickly be done, that's kind of the formula right now for the big, health centers. And I think the delayed adverse effects, which similar with opioids, but obviously, that we would see things like, people would come in with overdoses, clearly withdrawing, even though the system at large ignored, the numbers kept climbing. They didn't seem, the regulators didn't seem to care about that. But it's the adverse effects with these, with the hormone medications, it's similar. I mean, there's only like the upside of prescribing, but there's no focus on the downside. And I think that unfortunately, they've created a new class of patient. And this, again, the addiction analogy, it's very similar. I consider like the detransitioners really like gender overdoses. And I think that the complications they're going to have, and even for the folks who don't detransition, the complications they're going to have is kind of like complications from being over medicated or overdosed.
Medicalized,
that we need, that we're going to see, but of course it's not being tracked right now in a systematic way. So
yeah, wow, that's a really great perspective on that. And I remember I worked in a medical clinic, a primary care clinic in San Antonio for 5 or 6 years in the 2000s, and we saw mostly older, we had a geriatric population, mostly Medicaid, Medicare. And when we would get a new piece of equipment, we got a DEXA scan at one point. So it's like you're going to go through all the charts, and it's that marketing thing. Go through all the charts and look for anybody who's got codes that you can call them in to use this piece of equipment. And it had this very mercenary feel to it. Like we're going to pay this thing off.
Right.
And because we spent a lot of money on it. So ostensibly it's because you bought this because it's going to help learn things that are valuable for your patients in order to help them improve their quality of life. But there was this, there was this yucky feeling of, we're kind of using people to pay for this thing, and it's all about numbers and it's about dollars.
And not to say, and again, it's complicated, as because you could say like, and I'm not, up to date on like, was that original literature or studies, again, a lot of these things are like, the studies are horrible as to like, did all these people need that? But let's just say, could we identify early, it's like prevention. Could we identify people and then they can get on something? Because if you get a hip fracture when you're an older person and you end up in the nursing home, I mean, that's a lot of like the people get, there's an argument you could be made they try and make financial arguments, but from the human argument, you don't want your grandmother falling, getting a hip fracture, ending up in the nursing home, because there's so many complications cascade from that. So it's just that it's so bureaucratic, and so the nuance is gone, and because there aren't independent physicians and things, and the incentives we talked about, it does end up feeling yucky, like you're saying, where it's like, that would be great if we could find these people, but like go through every chart and call people, like what they might not need it. Like then you're doing unnecessary tests on people, maybe putting them on unnecessary medications, yada, yada, on and on. And so I think that's a great example where the good intentions kind of get into the medical bureaucratic machine, and it comes out where some people are getting harmed potentially.
Yeah, one thing that stands out from this conversation is the degree to which things have been bureaucratized, and the technology involved in trying to look at people at scale
Yeah.
is so dehumanizing that
Yes.
medicine loses touch with its purpose. And it also seems like the incentives that are created push things towards towards short-term outcomes like patient satisfaction rather than long-term
Yeah.
outcomes like
Yeah.
overall physical health.
Yeah. Yeah. Yes, that's true. And I do think in this age, obviously, with technology, the electronic health record, AI, data mining, decision support tools we didn't get into. They're just like little widgets and different add-ons in the electronic health record that, to me are very alarming but there's a generation of, people coming through that are used to everything being electronic and thinking that if, some decision support tool is going to have better judgment than them. And it's just filled with junk algorithms. It's kind of like a microcosm of how do you have doctors that are going to say, well, that decision support tool that's analyzing someone's risk for something is wrong, and I'm not going to do that recommendation. Right. That kind of thing is for us who are in, older generation, see that and see sort of, again, checkbox, decision support tool medicine by people who I think it's that have less contact with patients, that see how complicated and nuanced it is. But it's a big issue in healthcare and in, I think, medical training that is definitely going to be ongoing in terms of dealing with gender ideology. But even after we, the most unethical aspects of this are stopped, it's just, there's going to be something else, that fits in the pattern.
Mm-hmm. Decision support tools. It sounds like turning doctors into technicians. But do you see any hope for this? I mean, when you say things like after we stop the worst of this, that's great, because that sounds like you're optimistic that we're getting to that point. But do you see this getting any better? Do you think that people are really recognizing the problems that you're describing here, the overall systemic problems with structuring medicine this way, or do you think it's going to get worse before it gets better?
Oh gosh. So it's so the way I've processed this time is I feel that we're like a bridge generation. I think we're at the end of a cycle, breaking apart from a lot of policies from the 1960s now. And then again, people can kind of put the stake in the ground, obviously further back, like the Enlightenment, you get into the whole thing. I mean, one of my favorite books that I've read over the past, 3 years is Carl Trueman's The Rise and Triumph of the Modern Self, where he really pulls together, again, Rousseau's idea, where did the modern self develop? And it's just kind of this mix of Freud sexualized, psychology, and Freud kind of sexualized childhood, Marxism. I mean, all these threads that come together why is it the supremacy of the modern, if I feel this, this is me and you can't say anything else regardless if it's safe or not. So I feel that a lot of these things are coming apart, right? Because it's just gotten so absurd. And when you interact like we have with detransitioners, and you're so over intellectualized and so giving supremacy to what the modern self wants, that you literally have gotten yourself to rationalize that it's okay to do mastectomies on teenagers because they think they're another sex. Let's just step back a second. It's like the eugenics movement in the early 20th century in America, where you think that through Mendelian genetics, you can diagnose who's feeble-minded, quote unquote, and then you can eliminate them because that would be better for everyone because there'd be less poor people. So then we don't need to, you're like, okay, wait, stop. You're kind of saying you want to eliminate people. That you're over intellectualizing when it crosses over. And so I just think that I have never seen more and more people aware of these things. I've historically always kind of had these perspectives. I think, one of the things I didn't mention at the beginning is, my maternal grandfather is a Russian immigrant that escaped the Bolshevik Revolution in 1917. He was, a young man, 17, 18 years old. He was an engineer, starting to be an engineer in school, and Jewish. And basically that, it was like he would have to join the Red Army, and he and his brother escaped like through Poland. And, like you grow up with that story, and as also being Jewish, and with the Holocaust and how eugenics was taken up by Hitler and that whole thing. So my orientation, I just feel like when I see that pattern of tyranny, it's so obvious to me and has been. But what's different is that so many more people, I think, have seen this now. And so I'm optimistic from the standpoint that there are people like you and just so many parents and people going into medical centers going, why are they asking me about my pronouns, or saying this? That's the good side of the internet, that the exposure is much, much broader. And I think folks who are trying to change legislation are going about it in a much smarter way. So from that standpoint, I'm optimistic. But I think there needs to be a new sort of compact or deal with the way physicians are trained, the way they're paid, get some independence back. And that's a huge, huge cultural change that I think, again, I look at myself as trying to be, I think we're a bridge generation. Our obligations to teach about the past and try and be a bridge to something, that's better and ethical into the future. So I'm optimistic because I see, like I said, broader awareness. I see some very smart people, creative people trying to fight this, which is great. But I think it's we're like kind of in the sandwich generation. So I think the good side is, if you look at that as positive and exciting, because I like to build things, and in building something new and is kind of the excitement of being creative, which is, one reason, again, I joined FAIR, because it has allowed me to it's allowed me to build up something within healthcare that obviously in the hospital, there's no platform for me to talk about these issues. So I'm cautiously optimistic.
Well, yeah, that's great. I like that a lot. And it's a period of great difficulty, but also great potential and growth.
Yes.
So, where can people find you and follow FAIR and get involved in? Do you have some recommendations or links?
Oh my gosh. Yeah. Well, the broader organization FAIR, which is at, it's www.fairforall.org. That's where you can see the great work FAIR is doing. There's FAIR in the Arts that's tackling this illiberalism in the arts, FAIR in Education doing so many wonderful things. And then FAIR in Medicine is there too. It's in one of the drop downs. So you can find us there. We have a FAIR in Medicine Twitter handle in there. So you can find us there. We're doing a lot of collaborative work with other organizations that are doing, great things like GenSpect, Parents with Inconvenient Truth About Trans. We did a webinar last night about their book, Do No Harm, great organization that's, really tackling more on the legislative front. So you can find us also, working with these other groups. Hopefully you won't interact with me in an ER in the Chicago area. I don't want to see you there, but in terms of the advocacy, you can find us at FAIR at the website.
Well, awesome. Thank you so much, Carrie. It's been really, really great to talk with you and really enlightening. And I feel like there were so many different things that you talked about that I'd love to delve into individually at some point. So thank you for a really wonderful conversation and for the work you're doing.
Oh, my pleasure. And Leslie, you're just a a bright light in this whole movement. You're so bright and do such a great job. So thank you so much for thinking of me. Thank you.
Oh, thank you very much, Carrie.
Okay.